Everyone. I hope you all are doing well. Today's session is about palliative care in cardiac illnesses, and this session will be taken by Dr. Shoba Nair. She has done her MSc in palliative medicine, and she is a professor at the Amrita Institute of Medical Sciences in Kochi. She was also a former consultant at the Sheffield Teaching Hospital in UK, and she was a former associate professor at St. John's Medical College Hospital in Bangalore. This session will be co-facilitated by Dr. Punita Sharma. Dr. Punita Sharma currently practices palliative care in New Jersey in USA, and she has trained numerous residents and fellows in her role as the fellowship director for hospice and palliative care. She has been recently invited to serve on the New Jersey Hospital Association's practitioner orders for life sustaining treatment work group to improve end of life care for the state. So we know what all are her interests and we can have questions on that. So the first session for Dr. Punita and Dr. Shobha Nair will be from 7 to 8 and along with the questions, and we'll start with the case presentation at 8. So over to you, Dr. Shobha, and welcome to all of you.
Thank you. Thank you very much. Good evening, everyone. So Raju, do you share the screen or we share it?
Can we share it now?
Okay.
Just a second. We'll be sharing it.
So I'll be able to move the slides, isn't it?
No, ma'am, you will not be.
If all right. So I'll share the screen as of now.
Okay. Sure.
Because after some time, Punita will be moving the slides, or I can do that for Punita as well. Okay. One participant can share it at a time. Thanks. Yeah. Right. So today's session 9, Punita has named it as Matters of the Heart, as we're going to deal with cardiovascular system. So the objectives of this session is to understand the role of palliative care intervention in patients with heart failure, and why heart failure, we'll talk about that in a minute, and to explore the models of palliative care intervention in patients with heart failure. Just a few introductory slides on conditions requiring palliative care. As we all know, it is needed in chronic diseases and acute diseases. Chronic diseases, 38.5% is taken up by cardiovascular diseases, according to statistics, according to WHO. And cancer comes second to that, which is 34%. Diabetes, other kidney failure, chronic liver disease, etc., comes after that, much after that. In acute cases requiring palliative care, you have sepsis, COVID-19 as of now, traumatic brain injury, humanitarian crisis, to name a few. So we can see that cardiovascular diseases form a major bulk of chronic diseases that might require palliative care. Now, what do we mean by cardiovascular disease spectrum? When we talk about cardiovascular disease, we always think of the heart. We never kind of consider the peripheral vessels and the injury to that, or the diseases of that peripheral vascular system. So cardiovascular disease spectrum includes coronary heart disease, cerebrovascular disease, peripheral arterial disease, rheumatic heart disease, congenital heart disease, deep vein thrombosis, and pulmonary embolism. We all know that lifestyle, modifiable lifestyle, and unmodifiable genetic factors can give rise to risk factors like hypertension, dyslipidemia, etc., which can give rise to coronary heart disease as well as stroke. And genetic factors also can lead to stroke and coronary heart disease. So cardiovascular disease spectrum includes everything, and we need to keep that in mind. So in India, what is the epidemiology? What is the percentage of total deaths in India? This was a paper published in Lancet in 2018. Cardiovascular diseases, 28.1% of deaths in India um, was contributed to cardiovascular diseases. And in that, ischemic heart disease, stroke, etc., got the top slot. And after that came all the other diseases like hypertensive, rheumatic, heart disease, atrial fibrillation, endocarditis, peripheral artery disease, etc., etc. So 28.1% of total deaths in India was contributed by cardiovascular diseases. Now, if you look at the geography, you can see that A is total cardiovascular diseases, and you can see that the red color indicates more than 5,000 um, per 100,000 people. Okay, 5,000 cases per 100,000 people. In that, Kerala, Tamil Nadu, and Punjab have a high incidence of cardiovascular diseases. Um, and if you look at stroke, rheumatic heart disease, and the other one is ischemic heart disease, as you can see, again, Maharashtra, Kerala, Tamil Nadu, Punjab, etc. stands first. In stroke, you have Kerala again and West Bengal. And rheumatic heart diseases, again, infection, Kerala, Andhra Pradesh, Chhattisgarh, Odisha, Punjab, and Assam. So if you look at different areas in India, and if you look at the food pattern, you can generally kind of attach this to the food pattern in that region. Now, why heart failure? Why are we talking about this study? So final common pathway of all cardiac insults leads to heart failure, as we all know. It could be abrupt or insidious. It leads to enlargement, increased muscle mass, increased pumping, vasoconstriction, and end organ hypoperfusion. Okay, and there is progressive deterioration and premature mortality of these patients. Pathogenesis of heart failure, just one slide on that. Increased hemodynamic overload, as you can see here, normal heart, and there are a lot of triggers. And anything can lead to that hemodynamic overload, like hypertension, anemia, infections, and these are triggers. Ischemia-related dysfunction, so myocardial dysfunction, acute myocardial damage and remodeling. We have ventricular remodeling after that, after the damage, and excessive neurohumoral stimulation. As you can see the RAS activation, SNS stimulation, inflammatory cytokines, and endothelial dysfunction. So excessive neurohumoral stimulation and remodeling, abnormal myocyte calcium cycling, and excessive or inadequate proliferation of the extracellular matrix. So this calcium cycling, it is there, and it refuses to allow the heart to relax because the high influx of calcium in the myocytes, and that contributes to the dilatation and failing of the heart. Accelerated apoptosis and genetic mutations happen in this remodeling. So renal dysfunction, etc., and other organ dysfunction contributes to this hemodynamic abnormalities, and the structural modulations also contribute to this congestion, and which contributes again back to hemodynamic abnormalities. So what are the types of heart failure that we deal with in cardiac what do you say, language, we would say, cardiologists use this in this kind of terms. It is the heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. So preserved ejection fraction, mostly females and older adults. Ejection fraction is usually more than 50%. Stiff heart and better prognosis in medical management. So preserved ejection fraction, definitely better prognosis of medical management. And reduced ejection fraction, you have LV capacities is typically dilated. Ratio of LV mass and diastolic volume is either normal or reduced. And there is poor prognosis with reduced ejection fraction. We're all familiar with this NYHA heart failure classification. This is actually a functional classification, right? So class 1, there's no limitation of physical activity. Ordinary physical activity does not cause any fatigue or dyspnea. Class 2, slight limitation of physical activity. Comfortable at rest, but ordinary physical activity results in fatigue, palpitation, or dyspnea. And class 3, marked limitation of physical activity. Comfortable at rest, but less than ordinary activity results in fatigue, palpitation, or dyspnea. And class 4, unable to carry out any physical activity, symptoms at rest. So this is a functional classification. And we have stages as well, the ACs, the AHA heart failure classification. So stage A, patients are at risk for heart failure. They have not yet developed structural heart changes. That is those with diabetes, those with coronary disease without prior infarct. Okay. And stage B, patients with structural heart disease, reduced ejection fraction, left ventricular hypertrophy, chamber enlargement, who have not yet developed symptoms of heart failure. Stage C, patients who have developed clinical heart failure. And stage D, patients with refractory heart failure requiring advanced intervention. So biventricular pacemakers, left ventricular assist device, and transplantation. Now, let's have a look at how a typical heart failure trajectory will look like. You can see the NYHA classification and the stages here. So in stage A, as you can see, you have the propensity to actually develop the failure, but they have not developed it. They have all the risk factors. And once they have an ACS and there's a dip, okay, then they become steady for some time, and then different signs and symptoms happen. They have further dips, they become steady, but then there is deterioration. And you can see that stage D, there is refractory heart failure. So that during this time, progressive remodeling happens, and it reaches a stage where there is no recovery. So there are a lot of things that can be done during these phases to a large extent, and Punita will be talking about it. So over to you, Punita. Yeah.
Thanks, Dr. Shoba. Am I audible clearly?
Yes, you are.
Okay. All right. So good morning, everyone. Very happy to be here, and good evening. Actually, I'm realizing that the time over there is evening. So, what are some of the common symptoms that are associated with heart failure? So, when you think about it, broadly, it can be classified under symptoms that are associated with progressive pump failure, or symptoms that are associated with cardiac conduction abnormalities, and the associated functional and psychosocial decline that's associated with it. So we all know, we're very familiar with dyspnea, orthopnea, paroxysmal nocturnal dyspnea, fatigue, lethargy, exercise intolerance. Cardiac anorexia and cardiac cachexia is pretty common in advanced stages of heart failure. You would often see people complaining of cough, some chest pain, chest tightness, peripheral edema, ascites. They may be experiencing palpitations or recurrent arrhythmias. Oftentimes, I've seen patients who come in with altered mental status as a result of hypoperfusion. Depression, anxiety, and social isolation, again, very common in patients because of declining functional capacity. Next slide, please.
Dr. Shoba?
Yeah, I'm moving it. One second. It's just not moving for some reason. 1 second. Sorry. Seems to be stuck. Yeah.
All right. Okay. So very common exercise intolerance in heart failure. That's due to a decrease in the oxygen delivery and impaired oxygen utilization by the exercising skeletal muscle. And most of the times, the functional limitations that come are a result of this mismatch. Next slide, please. So what are some of the signs that we see in late stage heart failure? You would see that patients may complain, patients may be experiencing tachycardia, there may be pedal edema, patients may be having increased jugular venous distension, you may hear abdominal lung sounds in the form of crackles, some patients may develop bronchoconstriction, so you may hear wheezing as well. S3 gallop is common in advanced heart failure. you may see results of hypoperfusion in the form of cool extremities and mental status changes. On an X-ray, you might see cardiomegaly, you might see curly B lines, you may see cephalization of pulmonary vasculature, and you may see effusions, pleural effusion. And on an echo, you may see either reduced ejection fraction, or you may see diastolic dysfunction. Next slide, please. So management of heart failure, when we think of management of heart failure, the first thing that comes to mind is that, what is causing the heart failure? So it's very important to look into what's the etiology of heart failure and make sure that we are addressing that. Monitoring absolutely has to be done because this is a chronic progressive disease, and we got to make sure that appropriate medications are being used at appropriate time. The key to good health is preventative care. So, if we can make sure that we are practicing a healthy lifestyle right from the get-go, apart from genetics, which is not going to be under our control, we can make sure that, the likelihood of suffering from a cardiac disease, especially related to atherosclerotic heart disease, is decreased. Again, self-management, lifestyle changes, exercising, eating healthy food, making sure that we're not eating a lot of ghee. Thanks, Dr. Shoba, for your input on eating less fried food, less butter, less ghee, and making sure that we exercise daily for at least around 45 minutes and reduce the stress. Stress increases the catecholamine levels in our body, and that constant stress can place us into a heightened state of anxiety at all the times. And this is definitely not good for our heart. Pharmacological therapy, we are very lucky to have numerous pharmacological medications that are available for the management of heart failure. And not only that, now we have mechanical devices as well to be able to supplement the heart in case it's not functioning appropriately. And of course, the end stage management for heart failure is cardiac transplantation. Again, it's not something that is easily available. So, when we think of heart failure, let's start from primary prevention. Let's make sure that, we are telling our family, we are telling our patients to practice a healthy lifestyle. But on the other hand, if we do get diagnosed with heart failure, let's make sure that we are actively monitoring the signs and symptoms and actively managing it proactively so that we can prevent it from progressing into end-stage heart failure. Next slide, please. So this is a slide from the American Heart Association, which actually gives you detailed interventions that can be undertaken based on stages of heart failure, stage A, B, C, and D, as Dr. Shoba pointed out. So if you would see as we progress from stage A to stage D, the intensification of therapy consistently occurs. So for example, in stage A, if you look at the lower part, you would use ACE or ARBs in appropriate patients and statins as appropriate. When you move to stage B, the intracardiac defibrillators or revascularization therapy can be considered. Then in stage 3, again, further intensification of medical management that should be added. And once it's coming to stage D, that's when you require the advanced care measures, heart transplant. You may be requiring chronic inotropes. You may be requiring mechanical support. So all these decisions have to be considered at this point in time. And so palliative care has to be a part of this journey in a patient's life when an individual is diagnosed with heart failure. Next slide, please. All right, so I just wanted to, give you a little bit of a brief overview of how the intracardiac defibrillator as well as the cardiac resynchronization therapy works. And on the right-hand side, you'll see this is a picture showing how the left ventricular assist devices work. Rajalakshmi, can you see if these links are opening up?
Yes, we can see it.
Okay. Is it opening? Is it coming?
Dr. Shoba?
Okay, so if you look at this here, this is the cardiac resynchronization therapy, where the device is just implanted below the clavicle. So what happens is there are 3 wires here called the leads. The first one can sense the malignant arrhythmia, and the second one then can deliver a pulse to correct the rhythm back to normal. So you can see here the rhythm is abnormal here, but once the device gets activated, that's when it's able to resynchronize the heart and makes the heart muscles contract all at the same time. Are you able to see the graphic description, the video?
Yes.
Okay, all right. And I will now change the screen and show you the, 1 second, I may have to do it again. See my screen now? Yep, okay. All right, so the ICD, again, the ICD can be implanted under the clavicle, and it again detects the malignant arrhythmia like a VFib. And in response to the malignant arrhythmia, it is able to recorrect the rhythm here. So you can see here that once the malignant arrhythmia was detected, the ICD gets activated and it's able to give a shock, deliver an electrical energy, and able to reset the heart. Okay, I am going to stop sharing this screen, and let's come back to next slide, please. All right, so what are some of the predictors of poor outcome? Advanced age, definitely a very important predictor of poor outcome in heart failure. Advanced New York Heart Association classification. If your ejection fraction is reduced, as Dr. Shoba talked about earlier, folks with reduced ejection fraction and reduced cardiac index have a higher mortality. If you have a concomitant diastolic dysfunction, your risk of death is increased. If you have reduced right ventricular function or a low peak oxygen saturation with maximal exercise, and if you have end organ damage, as evident by low blood pressure, decreased pulse pressure, if you have CKD, and if you have an attenuated response to diuretics, all of these are markers for increased mortality. So when you see a patient with heart failure, and if you're seeing, these points in the diagnosis of a patient, you already know that this patient is at increased risk of death. So absolutely, time to introduce palliative care interventions. Next slide, please. Again, if you are on your maximal medical management and your symptoms are not improving, that's another predictor of poor outcome. Prognosis is often worse in patients who have diabetes and who have ischemic cardiomyopathy. S3, increased pulmonary capillary wedge pressure. If you have hyponatremia, if you have elevated plasma catecholamines or increased BNP, these are again poor prognosticators. Hospitalization for heart failure, it's a sentinel event. That means something is not right here. Patients are not being managed appropriately. This is an opportunity to further strengthen the disease-directed interventions. And if despite your disease-directed interventions, the patient's symptoms are not improving, then it's time to have the conversations and prep the patient and the family right from the get-go. Next slide, please. All right. So now, we talked about some of the prognosticators that were there. I also wanted to bring to your attention that there are additional prognosticating calculators that are out there. So the 2 common ones that we use are the Seattle heart failure model and the magic risk model. So these take into account patients, age, they'll take into account what is the blood pressure, what's the medical management, and what are some of the advanced therapies that the patient is on. And this is able to give you a predicted mortality for the patients. However, having said that, these models are not totally accurate. So the first and foremost thing being that, this may not be applicable to the population that we are considering. So maybe there is an opportunity to consider something like this in the patient population that you are talking about. And then population-based risk may not be the same as an individual risk. So what you're seeing in 5,000 patients may not necessarily translate to that patient who's sitting in front of you. So essentially, the results from these models have to be balanced against your clinical gestalt to make the most appropriate recommendations and plan for the patient. Next slide, please. So if you remember from our first session, we talked about when's the appropriate time for introducing palliative care and what are some of the domains that need to be considered. So when we think of heart failure, it's no different. The optimal timing for introducing palliative care is at the time of diagnosing of the heart failure. Now, you may argue that, at the time when a patient has been diagnosed with heart failure, the patient is not going to see a palliative care consultant at that point in time. However, having said that, the cardiologist themselves or the primary care physician themselves can introduce palliative care strategies into the management of patients' symptoms. It does not necessarily mean that the patient has to be referred to a palliative care specialist all at the same time. However, if the patient is in a very advanced stage of heart failure, that's the time to get the palliative care specialist into the interdisciplinary team who's managing the patient. And now when we look at symptoms, let's think about the symptoms across all the 8 domains. Next slide, please. I see a comment in the chat box which says share screen instead of the whole window. Are you guys able to see the whole screen or no?
We are able to see the entire presentation now.
Okay, all right, sounds good. Okay, so having said now, what are some of the directed interventions that can be undertaken here? So like I said before, despite advances in heart failure, it still remains a progressive, highly symptomatic, and a deadly disease that places a great demand on patients, their caregivers, and clinicians, and the healthcare systems as well. So things that we can start off with is first and foremost addressing the symptoms. Now, during the last session that we had last Saturday with Dr. Bhatt as well as Dr. Iyer, we talked about disease-directed as well as some global symptom management techniques for dyspnea. So if you recall, we talked about how you could use oxygen. We talked about how you could use opioids in the management of symptoms. Pain, again, could be, can we go back to the previous slide? Sorry. Pain, again, is a symptom that can be experienced by patients. So making sure that we are addressing the cause of the pain and providing interventions which are appropriate depending upon what the cause is. So for example, if a patient is having chest pain related to ischemic cardiomyopathy, making sure that we are addressing that versus if it is vascular pain due to peripheral vascular disease, we need to incorporate interventions that are directed towards that. Fatigue is very, very common in patients with heart failure. Apart from the appropriate management of the disease causing the symptoms, certain generalized interventions like optimization of your daily activities based on the diurnal level of energy that you may have. So it's not that you have to run the entire marathon in 1 hour early in the morning. What you could do is you could space out your activities and you could take things easy. You could do things, if you feel tired, you rest and then start over again. So that way it's spread out during the entire day. You don't have to do everything all at the same time. Depression, anxiety, psychosocial symptoms, again, very common in patients who are having heart failure. So it's important to address that. A common practice used to be before that we would prescribe antidepressants to these medications just recently I was reading, and cognitive behavioral therapy actually showed great results in patients with congestive heart failure. So a word of caution that when you're using antidepressants, SSRIs like citalopram and escitalopram are the preferred drugs if you're using those. But otherwise, cognitive behavioral therapy works far better as compared to the antidepressants. Again, management of anxiety by both non-pharmacological like relaxation, meditation, and the use of pharmacological agents like benzodiazepines is helpful. Discussions about prognosis and goals of care, very important to incorporate, right from the get-go. Often patients consider heart failure as something which is, yes, it happens, I take medications and then the symptoms abate and they think it's gone. Most patients do not understand that heart failure is a chronic progressive disease. As Dr. Shoba showed in the trajectory slide earlier, you will have those, troughs and valleys of symptoms. And as the disease progresses, those troughs and valleys are going to become more frequent. So having a conversation with the patient and family about how would they like to address each of those periods of decompensation when those happens, it's important to incorporate that into your conversation. And again, shared decision making in consideration for major interventions. So when you're seeing patients with heart failure, important to have some time to discuss these things. You could initially start off with something like, for example, yearly. What I do is, for patients who are stable as far as their heart failure is concerned, we would set up time, once in a year and just talk about what their overall goals are, how are they doing, what is their quality of life, and if anything has changed. However, if there is a milestone event where they had some decompensation or some other untoward event happened, that's the time to revisit those goals again. It's not just the patient. Caregiver burden is huge and often actually more than the patients themselves, because caregivers are handling the day-to-day activities and the day-to-day help that these patients require. So it's important to address the caregiver burden for families and friends who are taking care of these patients. Again, using measures to mitigate social isolation in whatever way and form that can be done. It's a great idea to introduce that to the patient. We are in the Zoom and virtual world right now. So, despite the adversities imposed by the pandemic, it did teach us that there are alternate ways of connecting with each other. Often what is not looked into when patients have advanced heart failure is how many pills they are taking. They have a pill for this, they have a medication for another symptom, they have another medication for another disease that they are suffering from. Does this make sense in the context of this particular patient that you're talking about? So for example, if you have an individual who is having advanced heart failure, end organ hypoperfusion, mental status changes, patient is not even awake, what is the utility of aspirin and statin in this patient? Again, this is a shared it's a shared decision making between the patient, if they are able to participate, and the family or the caregivers, and between yourself, so as to understand the risks and benefits of each and every intervention that is being undertaken, and how is it impacting the quality of life of this patient. Anorexia, again, very common in patients with advanced heart failure, despite the fact that you may see overall weight gain, but that weight gain is not healthy weight gain, because that's a result of fluid accumulation and it's not really muscle mass. So addressing that symptom right from the get-go is really important. Often what happens is family members think that they are not doing something, and that's why the patient is not eating. Explaining to them that the congestive heart failure does not only impact the heart, it impacts the whole body. When patients have advanced heart failure, they do accumulate fluid in their intestines as well. this reduces the absorption of nutrients. So they're not going to be able to absorb nutrients as much as they were able to do that before. There have been conversations about steroids, but usually I don't advise steroids for anorexia in these situations because, again, there is a risk of fluid retention, and that may further contribute to the problem. So yes, it may sound like you are addressing the problem, but you're not doing anything. It may seem like you're not doing anything from patient or a caregiver perspective, but making them understand the physiology behind this and how imposing food for these folks may actually cause more harm is beneficial. What we have often found here is that support groups are helpful. When people are going through something, and if they are able to talk their heart out, it often makes them feel better, and they are able to garner ideas from each other as to how they are dealing with it. And there is often that sense of community that that they are not alone. So incorporating support groups is also something which is beneficial. The intracardiac defibrillator deactivation, again, a very important point to consider for patients who have these advanced mechanical devices. We often forget that in the day-to-day conversation when we are dealing with patients with advanced heart failure. Discussions about ICD deactivation should occur early on when patients are able to make decisions for themselves. So the families at the time when this has to be considered are not really feeling that they are doing something to actively cause a patient's demise. If the ICD continues to fire when a patient is not responding to medical management, has not responded to any of the other advanced treatments in the management of heart failure, continuing to shock the patient, how does that impact their quality of life? And is that something that they want to do? So again, very, very important. And in fact, this is a conversation then more than the palliative care specialists, this should be introduced by the cardiologists. End of life care plan, absolutely essential. How do the patients want it and the caregivers want it to be? Often what happens is the last stages of an advanced illness of any kind becomes a series of hospitalizations and mechanizations and tubes and tubes in every orifice of your body. Is that how they would want to be, or would they want to be with their families in a much more comfortable environment and just focus on quality of life? So I do see some comments in the chat. What about the cardiologist's role in therapeutic plans, usually up to the terminal stage? Other than communication, family and patient support may be terminal dyspnea, rest-like device deactivations. You mean how much role has a palliative care physician has? We often think of palliative care as something starting after after all the interventions have been or disease-directed interventions have been undertaken by the primary treating physician. But let's think of it as something which can be done, simultaneously. So some amount of primary palliative care interventions can be taken by the cardiologists themselves. Management of symptoms, absolutely. The cardiologists can take them upon themselves to be able to address those things. Educating the patient and the family about how serious this condition is and what may be lying ahead and how will they plan for it. That's the best thing, our cardiology partners can do for us. I can tell you that when a cardiologist has had those kind of interventions, often I find that in those situations, integration of palliative care physician becomes much more easier, and the conversation becomes much more smoother when the concept has been introduced by the primary treating cardiologist. The patient already gets a buy-in. And as Dr. Shoba is going to actually talk about one of the trials that showed how integration of palliative care has improved the quality of life for patients, she's going to talk about it in the next few slides. We are not totally there where we have gotten the total buy-in from our specialists, But, when you have trials like what Dr. Shoba will be talking about, maybe that's an opportunity where you take it back to them and see, look, the integration of palliative care into the treatment plan of the patient has known to improve the quality of life for patients. And when it comes to patient outcomes, the argument becomes lesser and lesser. Then it's not about, you and me. It's about the patient's quality of life. It's about, what they want. It's about how we can make life better for our patients. When the conversation goes to that, I think, people would not disagree as far as that is concerned. So I don't know if you would remember, yes or no, but palliative care really gained momentum when there was a landmark trial which showed that patients with palliative care interventions, when these patients had cancer and these were undergoing chemotherapy, patients who have palliative care incorporated earlier into their disease trajectory actually lived longer, used less chemotherapy, and showed improved quality of life. So that landmark trial that was in lung cancer patients, that was published in one of the very respected journals, and I can send you the link a little later. That was one of the turning points in the history of palliative care, when patients when our colleagues actually saw that these interventions actually improve the quality of life, and in some cases have actually extended the quantity of life as well. Early on, I can tell you, yes, oncology is one of the common areas where palliative care integration happened early on, but yet there are many oncologists who did not, really get to buy in on integration of palliative care along with usual oncological care. Next slide, please. All right, over to you, Dr. Shoba.
Yeah, okay. Thank you, Panita. So I think we've discussed about different symptoms that can happen with patients. And we also should not forget that when we look at cancer patients, because of chemotherapy, some percentage of our patients are likely to have heart failure. Right now, we have a patient with us who's got dilated cardiomyopathy because of chemotherapy, and probably has gone into cardiac amyloidosis. So along with cancer, that patient has heart failure and severe breathlessness, and we're looking after that patient at the moment. So just wanted to bring to your attention this landmark RCT, which was published in the Journal of American College of Cardiology, titled Palliative Care and Heart Failure, the PAL-HF randomized controlled clinical trial. So I thought we'll just describe this in a few slides, won't take much time, because it's something which probably we can all attempt to do. Okay, so if you look at the methodology, they randomized into two groups, the usual care alone and usual care with palliative care. And they utilized the Kansas City Cardiomyopathy Questionnaire and Functional Assessment of Chronic Illness Therapy Palliative Care Scale. I think I have left one slide before the landmark thing. I just wanted to bring to your attention before we go into that study about the most widely adopted heart failure specific PROMs, which is the patient reported outcome measures. These are all available for you to kind of download and use it if you're interested. Self-administered 21 item Minnesota Living with Heart Failure Questionnaire, self-administered 23 item Kansas City Cardiomyopathy Questionnaire. And these two questionnaires actually incorporate multiple domains using Likert scales to quantify the presence and severity of physical symptoms and any psychological and social impact. And the other instruments that we commonly use for research purposes are all geared to evaluate PC needs. We can always use ESAS in this group of patients to find out what is their symptom improvement over a certain period of time, etc. IPOS, we all are very familiar, which is kind of originated in UK, and NAT-PDF, which is palliative care need assessment tool, progressive disease heart failure, originated in Australia. So if you're interested, you can all go and have a look at these tools. And then we talked about this landmark. We are talking about this landmark RCT, where they randomized into two groups, usual care and the usual care with palliative care. So they intervened at 0, 2, 6, 12, and 24 weeks. That means the study lasted for around 6 months. And this is the blue color is the usual care alone group, and the other one, let me check, usual care, and the blue line is the usual care and palliative care group, and the usual care alone is the red line. Okay, let's have a look at how they recruited patients. They screened and enrolled both hospitalized patients and recently discharged patients. That was only actually two patients who were at high risk of rehospitalization and mortality based on their ESCAPE risk score. And what is ESCAPE? Evaluation study of congestive heart failure and pulmonary artery catheterization effectiveness risk score. And multiple domains of quality of life for patients with advanced heart failure, including physical symptoms, psychosocial and spiritual concerns, and advanced care planning, were assessed and managed. So the intervention in the intervention group was physical symptoms were assessed, psychosocial and spiritual concerns, and advanced care planning was assessed and managed. So the HADS tool and FACET spiritual tool was also administered. So what did the results show? The patients randomized to both the group, that means the intervention group, had greater improvements in the KCCQ, or the Kansas City overall summary score from randomization to 6 months, with a significance of 0.03. And patients randomized into the intervention group in the FACET PAL scores also showed significant improvement. And depressive symptoms improved more in the intervention group with a significance of 0.02. And spiritual well-being also improved with a p-value of 0.027. So this landmark study, like Dr. Bonita was talking about, the lung cancer study in 2010 by Jennifer Temin, which was published in New England Journal of Medicine. I think everyone caught on that, and then there have been a lot of studies after that showing improvement with palliative care intervention. And I think that same group have published in different other cancer patients to show improvement with palliative care intervention. So this is considered as a landmark study in heart failure patients. Maybe you can read up and find out whether a small study can be done in your settings or our settings. So when we talk about how can we introduce this concept of palliative care, how are we going to approach the cardiologist and say, hey, look, I think your patients probably will benefit from palliative care. I think in Baptist Hospital, Bangalore, I think Dr. Stanley McKinnon always used to talk about a combined clinic. In geriatric patients, they used to have a combined clinic. And of course, in oncology, they used to get referred to oncology patients used to get referred to palliative care anyway. So you used to have combined geriatric patients, renal patients, etc. And that worked. So one of the models that I kind of read about is the palliative care physician attending a heart failure clinic once a week, 1 day in a week. And patients with palliative care needs, regardless of prognosis or disease severity, are scheduled to attend clinic on that day. And the palliative care physician may see patients with the team or meet with them individually. So Punita was talking about cardiologists themselves having a look at some of the symptoms. So once a patient is diagnosed with heart failure, the traditional heart failure management goes on, and then you have the primary palliative care, where you have controlled pain and you can control pain and other symptoms. The primary palliative care, that means the treating team themselves can assist in this. They can assist with medical decision-making and advanced care planning, assess and reduce emotional distress and burden to patient and family, coordination of care across patient's care team, and promote improved quality of life. I think we are all very familiar with this. And then there is the specialist palliative care intervention. I still remember seeing patients with intravenous drug abuse, and they have endocarditis and they go into heart failure. Especially in the UK population, there are a lot of IV drug users, and they come with end-stage heart disease, and they get referred to us. So in that is a specialist palliative care intervention. So the primary needs are actually covered by the cardiologist, and the specialist palliative care interventionists definitely have a role to play there. So when we talk about implementation of anything in our country, I think the best way to go about is talking to the concerned bodies, the professional bodies in a country. There was an end-of-life care pathway implemented, as you all know, by Dr. Stanley Mecken, Dr. Naveen Salins, Dr. Simha. All of them worked together on that with the critical care specialists to actually make an end-of-life care plan in the critical care scenario or ICU. And I think a lot of work has been done on that. So I think it's high time we kind of intervened and contacted all these people like Cardiological Society of India, Indian Heart Association, Pediatric Cardiac Society of India. We haven't actually talked about children in our talk, and I think the case presentation is going to be on a child. This is something which we can't ignore in children as well, because they congenital heart disease. And Indian Association of Clinical Cardiologists. So maybe the Indian Association of Palliative Care or Palliative India can take up this challenge and meet with these people, and we can make inroads. So ultimate goal, after all, is not a good death, but a good life to the very end. I think there are a lot of questions here. If you look at what are the further symptom management that we can do, apart from optimization of all these cardiac medications. Like Dr. Punita said, there are a lot of medications that these people have. And there's a pill box, and from which they just pop in medications. It's very important to make sure that these people are compliant with their medications. The example that I told you, the lady we have with cardiac failure and multiple myeloma, she refuses to take all these medications, and she ends up in hospital. So the first and foremost thing is to make sure that they're compliant. Can we reduce the number of medications that these people have? And when they get admitted for end stage or end of life care, there are ways and means by which we can definitely control breathlessness by subcutaneous infusions or of even furosemide. So we used to give. There's no IV access, so we can continue with furosemide subcutaneous infusions. I think Dr. Punita probably might mention to you about the inotropic support at home. Punita, do you want to talk about that?
Yeah, so patients with advanced heart failure who have end organ damage and hypoperfusion, and they are no longer candidates for your usual gamut of pill box that you have, including the diuretics, the ACE, ARBs, the ARNIs, as well as your spironolactone, aldosterone antagonists and all. So when they are no longer able to tolerate those medications due to a multitude of reasons, that's the time when inotropes like milrinone are introduced. And we have patients who are on these medications around the clock. They are receiving this on a consistent basis. But again, before you reach this stage, again, it's very important to have the goals of care discussion, that this is just adding another intervention to just prevent the heart from declining further, but eventually it is going to stop. So, if it's a question of buying time, and if it's consistent with the goals of care for the patient, sure. But is it actually curing the cause of the heart failure? No. So very important to distinguish between what is curative here and what is totally palliative here. And discussion of the side effects that these interventions can have in inducing further arrhythmias and all of those things, again, very, very important. So addressing the expectations and making sure that they are realistic, and patients and families have a broader understanding of what this therapy is actually entailing is critical.
So thank you, Punita. So I think we have just 3 minutes to the case discussion, but I think even during the case discussion, we might be able to sort of answer some questions. But if there are any burning questions right now, if anybody wants to ask.
So if we don't have any questions, we can start the case discussion, and we can have the questions after that.
Sure, okay.
We have a comment from Dr. Hari Mohan here. So he has written about if we decrease the medications, it is going to increase the symptoms. So
yeah, that's absolutely right, Dr. Hari. I think increasing the number of pills. So some of these medications can be in combinations. So we can actually reduce the number of pills or the time that they take these medications can be reduced into one, or from BD you can make it OD and those kind of things. So we need to really work on it. And like I said, this patient who is with us now, she is in that state because she's not compliant with those medications. Definitely, you're absolutely right. If they don't take the medications, they're going to be more symptomatic.
Just to build off on Dr. Shoba's comment, I mean, I look at it that let's look at it from the point of way that which is the most important battle to fight here? Which one do I pick up? So what's the most important pill or medication that we totally cannot do without? So that takes priority. And then you run down your list and see, which is something that is not being tolerated. So if a patient is not tolerating them, then, the issue becomes less distressing.
thank you so much, Dr. Punita and Dr. Shobha. We'll continue this discussion after the case presentation. So, Raj Lakshmi, can we have the case now?
Yes, yes, yes. Dr. Danila, you can start your presentation now.
Okay, good evening, everybody. I'm Dr. Danila. I'm from Argentina, but actually I'm living in Spain. I'm a pediatrician. I'm working here as a community pediatrician, but also I work in a very well-known NGO in Africa. So this case is from my last post in Africa. I was working in a pediatric intensive care there. Although it is a pediatric intensive care, the resources were very limited. Next. So it's a 5-month-old child with a diagnosis of tetralogy of Fallot. So the child was at 3 months of age, presented to our hospital with difficult breathing, irritability, chest syndrome, and low saturations. The past history, this baby that was a health term delivery. At 1 month of age, she was admitted into another facility with pneumonia for 5 days, and then she was discharged clinical well. On examination, as I said before, we have a few resources. So we have a lab test showing a hematocrit of 70, low platelet counts and coagulation factors. We test her for HIV and malaria, and we are negative. We have the possibility to do an ultrasound, and the ultrasound reveal image compatible with tetralogy of Fallot. So for the treatment, this child was having TET spells every few days at the beginning. And after 1 week of admissions, TET spells were every day, so we use morphine for that. We prescribed propanolol. She was with oxygen by nasal cannula, and we feed her with formula. The social, psychosocial aspects and family concerns. The mother died 2 days after the delivery. Her aunt, mother's side, was in charge of the baby. The father was aware of the disease of the child, but she works in the rural area, 100 kilometers from the capital. He is the only financially support of the family. Someone in the community told the aunt that another NGO could take the child for surgery to Europe, but was not a possibility. So she strongly believed in this possibility, and she didn't want to go home with the child. About the spiritual concerns, the family believed that her situation is the curse of God and her relatives. Her aunt is very tired of caring for her, and as it was very difficult to be with the baby at hospital and do their activities, the child was with us like for 4 months. That's why the aunt was very tired. She continued to take care of her because she believes that it will help the family to get mercy from God, as they have done a good job. The family pray that she will be cured and able to enjoy a normal life. Well, the main concern was the communication. At that moment, we were implementing a palliative care program for the first time in the country. So the physicians' skill in communication was very poor, and they feel unable and ill-equipped to manage such difficult clinical situations. So every day the social worker was the only one visiting the child and talking with the aunt. Other members of the family were fully informed about the health of the child, and they also frequently visit and support her aunt in the daily care of the baby. So after 5 months, and we worked very hard with this family, the aunt decided to go home. So we made a plan, and about the feeding, we told the aunt to feed only for comfort, smaller, more frequent meals of high-calorie foods. We told them that were the best. For the tete spells, we use muffin, and we taught the aunt to positioning of the knees to the chest, or the squatting. We told them that maybe can help the baby. And she went home also with propanolol. For the breathlessness, we treat with morphine and midazolam. And for the pain, we treat with morphine. So the discussion point, I think here was the communication with the family. So what are their concerns? What psychological supports are available in the community and in the hospital, and what are their preferences? And the symptom management options, what are the options at hospital, and what are the options in the community? Thank you.
Thank you, Dr. Daniela. Can we have inputs from our faculties and also Dr. Anne? She's there.
I can start while Anne is either logging on or
sure, ma'am.
I'm not seeing her. But this is really tough. I mean, as I was listening to the case, my first question that comes to mind is, what are the disease-directed interventions that are available over there? Was surgery ever an option? Is that available in the country or no?
No, it's not available. No, so yeah, all these, we have many cases like this. So we have to manage at home. But
that makes it.
Yeah.
That's really, really challenging.
Yeah. Also, the nobody controlled the pregnancy, so nobody knew that this child had a tetralogy of Fallot. That's why she was admitted in another hospital for pneumonia, because she was with low saturation since she was born. So everybody was treating her like a pneumonia for 3 months.
This is Ann Broderick. I'm wondering what role the chaplains had as this family's faith was extremely important to them. Was that a resource that you had in that setting?
Yes, someone from the community that the family knew came every day to the hospital and and pray with them and
Because it also seemed that they may have had guilt about why this happened, or the misdiagnosis. And I would think that the existential distress that they were having would be best managed by a spiritual counselor or a chaplain. So I'm glad they had that. That's wonderful. I think the management, given the lack of surgical interventions, was brilliant, and the recognition that the family was tired, and that they were acutely grieving. They lost the mother of this baby, their sister, presumably. Lots of things were going on. I think the management, given that surgery wasn't an option, I think the management was brilliant in a low resource environment.
Thank you.
Danila, another question or thought that came to mind was, now that the baby was discharged from the hospital and is back at home, so now this becomes a 24/7 job for the aunt.
Yeah.
So question is, what support systems could we have considered or put in place, once the aunt went home with the baby? Were there other family members? I know you mentioned that, the father is the breadwinner, so he's probably, working. So he's not going to be able to spend as much time in caregiving. Were there any other, support systems around?
Yeah, another friend of the aunt came every day, and when the aunt went home for take a shower or something like that, another friend for her were around. But I think that the main discussion here is that the family, well, at the beginning, she doesn't want to go home because she was very worried to have this child at home, and it's completely understandable. But then after 4 months, she was like, okay, yeah, I want to go home. But all the doctors were, no, you have to stay here. And that was like very stressful for her also. Because we were doing a lot of things, but things that she could do at home as well, like to give morphine and etc.
And what was the medical support plan that she had? Like, was she able to, let's say, if she had any question, were there plans put in place where she could call in a physician or a nurse to, run the challenges by them?
Yeah, when we discharged her, we gave like a phone number. So she was calling us every now and then. And also nurse every day went to her house to visit the child and the family.
Okay.
The child died like nine months after discharge. So she was alive like 1.5 years or something like that.
Yeah, I was going to ask you that, Danila. It's like, did they know about the prognosis and that the child ultimately that was going to happen? Or was it a shock to them?
No. They knew. They knew.
They knew about it. Okay.
Yeah.
Do we have any questions from our participants?
One question that I see is home oxygen support to the baby. Was that provided?
No. We discharged home without oxygen. This child at the end doesn't need oxygen because they can live with low saturations. So we didn't give her oxygen.
see, there is a possibility that we can see such cases in rural India as well. There is a possibility these scenarios, like this sort of concerns with the family about the curse and the caring for the baby. These things might also happen. So, like this was a good case, and I see we don't have any more comments regarding this case. But do we have any more questions for palliative care and cardiac illnesses?
Ma'am, I just have a small question if I can ask it.
Please.
Please go on. Please go
Ma'am,
on.
as you mentioned that there might be some similar cases in rural India. So I have come across two of such cases in a lower socioeconomic group. And what I noticed was that both the parents, they ran from pillar to post. They kept sweating their nerves out in various hospitals. They used to visit each and every place that people used to tell them, be it some spiritual place or some Ayurvedic or some hospital. Ma'am, I just need to ask you that should palliative care as an option, including counseling of the parents, be integrated at a very early stage by the pediatricians or the cardiologists in such case, and the prognosis nicely explained to the parents so that they don't burn out with this process, which is very heavy. I mean, one, an ailing child, two, kind of having an idea that something not so good is about to happen, and three, the complete exhaustion of all their resources. So, ma'am, should it be an option? I mean, can it be done?
So, Geetika, you bring about excellent points. First thing that comes to mind is, a good prenatal care setup. And, that's something in communities, that can be education about that can be spread, that, we are there to help you. So starts from that. So once you have a mechanism to provide good prenatal care, that's when you can detect all of these abnormalities and put mechanisms or systems in place to address those abnormalities. I can tell you that, in our setting over here, whenever any pregnant woman gets diagnosed with, the baby gets diagnosed with a condition that is not going to be life sustainable, we often have discussions with the patients and their families upfront. And there is the pediatrician, there is the obstetrician, there is a palliative care consultant, and there is the genetic counselor. So if you have an individual who is going to be delivering a child with a condition that is not going to be compatible with life, we have those discussions upfront and we put plans in place. Of course, this is a big undertaking. It's going to require, a lot of systems and support to be put in place. But hey, start off with the seed, and you have the seed right there.
Yes, ma'am, I agree with what you said. But looking at the Indian scenario, most it's difficult to find such type of setting in like most of the places. Like only big hospitals have all these facilities, and even if they have, so many people are not able to afford these facilities and the prenatal care and the good level of treatment. So this becomes an issue for a lot of people who may have children diagnosed with such type of abnormalities.
Ma'am, in my own case, I had some issues in my pregnancy, and I was seeking help at real good centers. I don't want to name any, at good places in the metropolitans. But the guidance that ma'am just spoke about, that Dr. Punita just talked about, was not there. Despite being from the medical field, despite of going to the good centers and knowing good people in the field, it was not available. So it's everything's left to the patient to decide, and you are given a big array of options which you don't completely absorb and understand, and ultimately you're left confused just to sit and think about the destiny and accept it as it comes, which is very unfortunate. That is what I had put forward this question for.
Yeah.
Geetika, this is a,
Because
can't even, don't even have words to say what you and your family must have experienced. But having said that, look at the forum where you are today, right? And when I look at Pallium India, look at where this organization has come from a grassroots level, and look at the number of people that they are raising awareness in. So you guys are the catalysts of this reform movement. You are the people who can take this a step further. So think of it from that context. Like Dr. Shoba pointed out, what are some of the ways that palliative care can be integrated with the cardiologist? Starts off with a single idea, a single point of discussion that you start off with your colleagues, and then you keep building around it. So, think of it from that perspective. And there may be folks who may have shared interests, and that's when you continue to build your momentum. That's one of the cause, or one of the missions. If you have like-minded people, they can further this mission even further.
And one more point I wanted to add, Geetika, just to let you know, in our institution, we have a department of pediatric cardiology, and they have actually invited us for a mortality meeting, the palliative care department. In fact, they've asked for help to set up mortality meeting. And I think that's a place where we can actually intervene and say, okay, we can lay down, of course, when you're looking at the deaths and how easy or how bad it was, or what were the difficulties that these patients went through, and can we put in a process where this can be reduced and the patients made comfortable. So that's what we're going to look at. So we've been asked for some help just a couple of days ago, and we said yes, we're going to definitely help them to set up that mortality meeting. It's a newly formed department in the institution, just under a year, pediatric cardiology, and they're doing good work. So they wanted us to do that. So this is one straw where we can just hold on and climb into and make a difference, is what I feel.
Thank you, ma'am. Do we have any more questions? I suppose we don't have any more questions.
Gauriya, if there are no questions, I would like to get 1 minute.
Sure, please.
So there were many questions regarding methadone questions. So we have not received enough replies. So we are waiting for more participants to answer the questions. So